Our case-based presentation is on transverse myelitis and spinal cord injury. Our patient is Mrs. Darcy Ropper. She is a 47-year-old African-American female. She currently is living in Touro Institute for Rehabilitation on the spinal cord injury floor. Mrs. Ropper presents with T5 Asia C paraplegia as a result of transverse myelitis. She has been in acute rehab for 2 weeks with 3 hours of PT and OT services daily. What is transverse myelitis? Transverse myelitis is an inflammation of the spinal cord and is therefore considered to be a spinal cord injury.
So what are the symptoms of transverse myelitis? They are described as a band-like sensation across the trunk of the body with sensory changes below. They can be accompanied by pain, sensory problems, weakness in legs or arms, and bowel and bladder problems. Symptoms may develop suddenly over a period of hours, days, or weeks. Our patient complained of numbness and tingling in her legs, tripping multiple times, and not being able to stand, and her symptoms developed over 3 days.
Treatments for transverse myelitis are aimed at preventing or minimizing permanent neurological deficits. The use of corticosteroids or immunosuppressants decrease swelling and reduce the immune response in the spinal cord, which may be contributed to the inflammation. Other drugs may be useful in reducing muscle or nerve pain, such as NSAIDs or gabapentin. Our goals in physical therapy are focusing on helping the patient become as physically independent as possible by gaining strength and coordination, reducing spasticity, helping to regain more control over bowel and bladder, and learning to use assistive devices effectively.
What causes transverse myelitis? The exact cause of transverse myelitis is unknown in many cases. This is what we refer to as idiopathic. A number of conditions have appeared to cause transverse myelitis, including immune system disorders. Our patient has a family history of multiple sclerosis from her mother. Viral infections. She has a history of shingles and vascular disorders. Our patient is a smoker and smokes half a pack of cigarettes a day. Some other causes are bacterial infections, fungal infections, parasites, and other inflammatory disorders. What is the prognosis? Studies show that the sooner a highly coordinated, comprehensive spinal cord injury rehabilitation program is initiated, greater gains are likely to be achieved. Patients are expected to experience at least partial recovery. Most of recovery takes place in the first 3 months after onset, and if there is no sign of improvement in the first 3 to 6 months, complete recovery is unlikely.
So our patient is T5 Asia C, but what exactly does that mean? So the Asia scale was used to determine a patient's current neurological level. The scale ranges from Asia A, being a complete transection of the spinal cord, to Asia E, being normal function. We assess impairment using sensory and motor tests. So sensation is evaluated with both light touch and pinprick sensation across dermatomes on both sides bilaterally. Motor function is scored similar to MMT, but we're looking at fatiguing weakness. So we just hold a contraction for at least 5 seconds, and we test 10 key muscle groups bilaterally, ranging from C5 to T1 and L2 to S1. Their neurological level is determined as being the lowest level with fully intact sensation and at least a 3 out of 5 muscle grade with 5 out of 5 scores above it. This is a typical Asia scale score sheet, and you'll learn plenty about it in clinical neuro. So her neurological level of injury is at T5, and she's Asia C, meaning that it's an incomplete transection of the spinal cord. She has preserved motor function at sacral segments for voluntary anal contraction and deep anal pressure, so sensation and motor. She has some sparing of motor function at least 3 levels below the ipsilateral motor level on either side of her body, and less than half of the key muscles below T5 have a grade of at least a 3 or more out of 5. So what is paraplegia? In its simplest definition is just paralysis of the lower extremities. And our patient presents with a significant decrease in motor function in bilateral lower extremities.